neurologist and the director of MS clinic at Amiri and Ibn Sina Hospital. He received his degree in medicine from Charles University. He completed neurology residence and the fellowship in MS at University of British Columbia. Dr. Al-Roghani established the National MS Registry and the multidisciplinary MS clinic in Kuwait. He is authored more than 150 publications. Dr. Al-Roghani is Secretary General of Minecterms, Vice Chair of MS Base, and member of Big MS Foundation. Now Dr. Al-Roghani will present updates in MS management. Please welcome Dr. Al-Roghani.
Thank you, Dr. Samar, for your kind introduction. I thank the scientific committee for the invitation. I'm going to talk about update in the management of MS. I think I have less than 30 minutes, so I'll try to be very precise. These are my disclosures. Now, as you know, MS has a big burden on the quality of life. Overall, on the long term, most patients will progress in a certain time. And also there is an economic burden with the loss of employment, the cost of hospitalization, and also the treatments along with the rehabilitation. So far, the treatment probably has a big impact on both these burdens and affect the overall quality of life on the long term. In the last decades, 2 decades, we've seen in the last decades, we've seen at least 3 revised criteria for the diagnosis of MS, and the latest criteria was McDonald's criteria in 2017, where now we can actually get the diagnosis faster with the help of oligoclonal bands in the CSF. And this will probably help the fulfillment of the dissemination in time. So we all know that we have to start very early because probably the acute phase has also a big impact on the long-term disability. We all know by the paper published by Traub in 1998 that even with the acute lesion, you will see acute axonal loss and sometimes a transaction of these axons. So if you don't act very fast, even in the relapse time or the inflammatory time, you may end with a significant disability. And over the last 2 decades also, we learned from the clinical trials that those patients will progress no matter how at a certain time. Some patients may progress or enter the second phase, which is secondary progressive phase at between 0 to 5 years. Some people may take up to 30 years. So we don't know where is this turning point. So each patient has a specific trigger for his transition into secondary progressive MS, and we don't know why. So we probably need to treat very early to avoid or to delay the transition phase. The second lesson that we learned is once you treat early, you're probably gonna change the overall prognostic factors with MS. Also, we learned from natural history that relapse rates and especially in the first 2 years are very important. And the EDSS actually may be delayed to EDSS 3, 4, 6 once you start very early. And if you have too many relapses in the first 2 years, you may actually go and progress very fast. Similarly, we saw a big impact of the DMT in the prognosis of MS. So if you take the milestone, which is EDSS-6, which is using a cane, in the era between 2090 and 2010, we saw a significant reduction of the percentage of patients reaching EDSS-6. So 84% risk reduction. And this is a very important point. This tells you that the treatment works. And this is done by Capra et al., where they assist and they did a retrospective analysis of a big cohort over 30 years. So I think this is very important message that yes, DMTs will work. The new DMTs probably have a more potent effect on the natural history. Before we tell patient you may reach the cane after 25 years, we can say no, you may. With the old DMTs, we tell patient you may reach the cane at age or with a duration of 15 years. Probably now we can say no, this will take longer, maybe up to 25 years. So at least with the new DMT, we're delaying. And this was also supported by the paper that was published in JAMA in 2019, when they assessed patients who are on treatment and those who are on high DMT and low efficacy DMT, so high efficacy and low efficacy, and they assessed the natural history of the disease. And they found out that those who were started on high efficacy medication convert later to secondary progressive MS. So yes, medication work, and high efficacy medication probably works better to delay the secondary progressive. And the rationale for early treatment is straightforward. And we know that damage may happen very early in CNS, so you need to prevent it because most of these damages are irreversible. The repair system is actually much and more efficient earlier on. And most of our drugs are inflammatory drugs, and the early phases are inflammatory. So once you delay it, you may enter into a less inflammatory with less impact of these medications. Now, in terms of the proposed mechanism of action, so we know most of the medication in MS has a specific mechanism of action. However, some of the older drugs, such interferon and glutamaterase, they work on different mechanism of action. That's a specific one. And also dimethyl fumarate is one of also the medication that has more than one mechanism of action. But overall, we are talking about the pleiotropic effect on the interferon dimethyl fumarate. We're talking about the targeted cell depletion, especially with CD20, like crolizumab or the new medication of rituximab, rituximab as well, or CD52 depletion with alemtuzumab, and also the CD20 or the cladribine, mostly driven by T cells. Also, we know the teriflunomide, which works on the reduced proliferation through the pyrimidine pathway, where they block the rapid cell apoptosis. And we know more about the anti-migratory, where they, with natalizumab, where they block the entrance of anti-inflammatory cell through blood-brain barrier, or blocking the egress of the mostly T cells in the lymph node with the S1P inhibitors. And as we know, there are 3 medications now with the S1P, 1 already approved, and 2, which is siponimod, and ozanimod and ponesimod are coming very soon to the market. The new concept nowadays for the treatment is probably gonna go more into what we call immune reconstitution, or the induction therapy, or sometimes we call it pulse therapy. In the past, we used to go through what we call escalation. We start with the first line. Once you fail or have a breakthrough disease, you go to the second line, and then third line, and so on. The new concept, which is the immune reconstitution, is where you administer 1 dose, second dose sometimes, and some patients may need a third or fourth dose, but not all patients. But this is less frequent, and also with more adherence. However, this has an issue, especially when we talk about a strong immunosuppression. There is an increased risk of infection, leukemia, but on the other way, has very effective targeting. These are very effective in targeting the relapse rate and progression. So these are the evolutions of DMT. Prior to 1990, most treatment were anecdotal, where they use azathioprine or pulse steroids. And then in mid-90s to early 2020s, then mostly were interferon and glatiramer acetate. Natalizumab came in 2006. The first oral came in 2010, fingolimod, and then over the last decade, we've seen a plethora of medication coming, and also going from the escalation, the maintenance, into what we call non-continuous administration, of what we call, immune reconstitution. So far, every year we are getting a new drug. This year we got siponimod, and last year we got ofatumumab. Both will be coming very soon to the market in Kuwait. Also cladribine was introduced 2 years ago. So you can see there is lots of changes even in the algorithms because of the fast update in the treatment arms in the world. So when we talk about how to choose DMT, there are several factors. I think these are the main factors: whether the medication is effective, whether it's safe, treatment burden or monitoring burden, and pregnancy and family planning. So these are 4 pillars when you think how to choose certain treatment. So in terms of disease efficacy, we all know that most of us will, the objective of treating any patient is actually to prevent secondary progressive course and to prevent any disability, whether it's physical or mental. So we try to assess most of the medication in the short term through the use of NEDA, no evidence of disease activity, where patients have no relapses, no MRI changes, and no disability progression. Lots of analyses are done with the NEDA to compare one drug to another drug, but this is not gonna be easily judged because each trial has different arms with the baseline characteristics. And NEDA is linked mostly to the short-term clinical outcomes, but probably the long-term outcome is probably trying to get the prevention of disability progression. So these are the NEDA-3 rates across the few of the high efficacy medication. So this is ocrelizumab, cladribine, ofatumumab, alemtuzumab, and you are talking about a NEDA of 30 or plus and reaching up to 50% when compared to either a comparator arm or a placebo arm. So although we cannot say yes, one drug has a better NEDA than the other drug because of the differences in the baseline characteristics and patient population of different trials, but at least we know that the NEDA, when compared to a comparator, is actually much higher. So now we are talking about a new era where we have not only a second-line treatment, but actually a strong high efficacy medication where it may actually act very fast in the first 2 years. The second factor is safety, and we all know that most of the drugs has side effects. Some of the side effects are common, and some of them are very rare and deadly. However, if you look overall, when you go to discuss the safety of DMT with your patient upon the initiation of any treatment, most of us will talk about the common side effects, which are very common. The rare probably need more caution, and when we talk about rare, and we all know the impact of PML on natalizumab, which is uncommon and very rare in dimethyl fumarate and fingolimod. Alemtuzumab has also a build-up of a list of infections that's coming vascular also events coming. So these are very rare, but we have probably need to talk to patient about those. Where most of the drugs has a risk of infection, because we are, modulating or depleting the immune system. And the infection rate actually differs from one drug to another. We all know that interferons and glatiramer have no increased risk of any infection. Once you go to the high efficacy medication, you're going to see more towards common and very common. Most of these infections are bronchitis. We all worry about herpes zoster because it may disseminate into the CNS, and that's why we always advise patients to take to be vaccinated against the VZV, if not done prior to the treatment, for at least 6 weeks before any treatment. And also now in the COVID area, we always also like to vaccinate most patients. And when we talk about COVID, I'm not going to go into much detail, but to tell you that most patients who are on different medication have no increased risk of developing COVID, except maybe a slight increased risk of severity of COVID, not contraction of COVID, in patients with ocrelizumab. But this is important, factor when we talk about DMTs and infections. So far, no severe outcomes been associated with the medicine in particular, except for slight increased risk of admission to ICU and severity with ocrelizumab. Talking about treatment burden, we have lots of medication nowadays with lots of side effects that we have to monitor. We all know that the most, monitoring burden will come with alemtuzumab, where you're going to do the monthly CBC, LFT, RFT urinalysis, and the 3-monthly TSH over 5 years. So this is a very heavy burden. The burden with the first line treatment is usually negligible. You're only going to do a 3-monthly or 6-monthly CBC, similar with dimethyl fumarate, similar with the cladribine. Once you go to the infusions, the burden of natalizumab is probably not that high, except doing the JC virus every 6 months. However, it's an infusion, a monthly infusion, and also in the very soon you're going to see the approval for the 6-weekly, which being used actually in most of the hospitals after the COVID era. Probably the data coming from the ECTRIMS supporting the use of 6-weekly, what we call extended interval dosing of natalizumab. Finally, pregnancy. We all know that most patients of MS are women of childbearing age. The actual proportion of patients who got pregnant after diagnosis has increased in the last 2 decades. And probably this tells you that they are feeling much better, or they started very early with a good medication, and then they will consider pregnancy. So it's a big impact here. So that's why treating the patient early, and once the patient feel they are in remission or have very mild disease, they will consider pregnancy, and that's why we are seeing more pregnancy nowadays. Now, some practical consideration relating to family planning. So we always tell the patient, upon just the initiation of any medication, we bring the pregnancy factor or the family planning factor ahead, and we tell them before choosing the first medication, yes, which medication you can get pregnant on and which medication that you should not be on when conceiving. So we divide these two kind of recommendation into 2 dichotomies. If the patient is stable and not taking any medication, we probably tell the patient go ahead with a pregnancy. There is also with a new approval for interferon and glatiramer acetate. These medication can be used during pregnancy and also during lactation. So if a patient is not taking any medication and planning to get pregnant, then they can do this. Now, if a patient is already on a treatment and stable with no relapse, we tell them continue the medication until the confirmation of pregnancy. If the patient in what we call highly active disease and on high efficacy medications such as natalizumab, we tell them to continue with natalizumab until the 32 weeks of gestation. Now, the big issue here when in talking about patients who are taking high efficacy medication like fingolimod, we have to worry about the disease reactivation. And we actually have a plan where we tell patients to de-escalate very slowly with either every other day and then probably a month of being off fingolimod before we bridge or try to get the confirmation of pregnancy very faster. So we don't want to leave patient off medication, especially after fingolimod, for more than 2 months. And as we all know that patient has to stay at least 2 months off fingolimod before they get pregnant. It's different when a patient is newly diagnosed, highly active, and not on treatment. So here, probably we have to think about the disease before the pregnancy. We always tell patients who are very active not to get pregnant in the first year. We need to stabilize the disease with all the factors we indicated previously. We have to engage into discussion. Maybe a patient needs to delay this pregnancy planning for a year. So we initiate the medication depending on the status of the disease. So if a patient is highly active or aggressive, we go with high efficacy medication. Probably also we have to think about a medication that the patient may get pregnant on, like natalizumab or dimethyl fumarate, which are not associated with any risk of rebound, not associated with any teratogenic effect. Try to avoid fingolimod here when in a newly diagnosed patient who are planning to get pregnant in a year, because you're going to end up with the same case scenario that we discussed previously. Few points on the algorithm, how to treat.
Dr. Raed,
yes.
You have 3 minutes more.
Sure, I'm going to finish on time, inshallah. So just few points on treatments updates. We all know the radiological isolated syndrome, where a patient have fulfilled the ACUDA criteria of the MRI, but patient have no symptoms. The current evidence with the current support from all the recommendations are not to support. You can monitor, but you should not start any treatment before the clinical event. And this is across all experts. Sure, you will see evolution of MRI changes. You will see GAD enhancing changes, but again, there is no evidence so far to start. CIS, I think it's now rarely to see CIS, especially with the new criteria. But again, we put this just for a reference. Patients who are high risk, like severe relapse with the first attack or significant disability or high lesion load, you treat as MS. And rarely you're going to see CIS nowadays with the new criteria. Now, for the relapsing remitting MS, and I think we all agree that there are patients who are active but have a good prognostic indicators, those with highly active where they have 2 relapses but still recover quickly, and those with rapidly evolving severe MS where they have a very disabling relapse, high lesion load. So we separate those and we dichotomize those, and because each of those category has a different treatment. We always think about a suboptimal response. You always think when to change the treatment. I think we all agree a patient has a relapse, an MRI change, there is no question. If a patient has only a 1 lesion or 2 new lesions, you probably need to wait or at least do another MRI in 6 months. So this is the recommendation for patient with active MS but no poor prognostic indicators. You're going to see the first line, the interferon glatiramer, teriflunomide, dimethyl fumarate. If they fail, you go to the second line, like cladribine, fingolimod, natalizumab, they go, and then, or plus, you can always combine second and third line when a patient is failing. With highly active and rapidly evolving, you're going to see mostly the infusion, natalizumab, ocrelizumab, and sometimes alemtuzumab, along with the new orals like cladribine, and probably gonna see fingolimod, siponimod. Ofatumumab probably gonna come into play over here. Finally, 2 slides about progressive MS. Now we lump progressive MS together. Probably the histopathology are very similar. Now, both have cortical demyelination, both have significant impact on the axonal loss. So we try to lump them, although the age probably difference, there is a difference in the gender and also overall in the long-term disability milestones. But according to Lublin criteria in 2013, they tried to lump them and call it progressive MS, and then dichotomize them into active with a progression, active without progression, not active, but with a progression, or stable with no activity. And this is probably going to help when choosing a treatment. These are all trials being done on different DMTs, which failed in progressive MS. So it's a disease where we have a significant demand to find a good treatment. Ocrelizumab was the first treatment, was approved mainly for PPMS with a risk reduction of around 24% in the confirmed disability over 12 weeks through the Oratorio. There was a question whether you need to only treat patient with a GAD-enhancing lesion, but I think the study tells you clearly there is no difference whether the patient has GAD-enhancing or active lesion or not. Siponimod was approved for SPMS, and it's coming to the market. I think in Kuwait, probably going to be starting using it next month. Again, significant reduction, around 25 to 26% against placebo. These are the recommendations from ECTRIMS and American Academy with respect to progressive MS. You in active secondary progressive MS, you have to start a treatment. So the recommendation either ocrelizumab or cladribine. However, we know that cladribine has no trial against SPMS or PPMS. I think this is all data extracted from the 10-year long-term data of cladribine, but there is no head-to-head trial or a clear trial specified for PPMS. For PPMS, ocrelizumab is the only approved. American Academy is much open when we talk about progressive MS. They cannot tell which medication for SPMS. I think we all have issues with SPMS. We always try to use whatever we can. In Kuwait, mostly we use ocrelizumab, rituximab for secondary progressive MS because most of those patients have gone through lots of medication before we diagnose or before they transition into SPMS. With this, I'll thank you for your kind attention.
Thank you, Dr. Raad,